So today we'll be starting or continuing our resident lecture series. We have two presentations. The first one by Justin Nguyen on the medical expulsive therapy for ureteral stones, and our second presentation will be by Danny Segal on shockwave lithotripsy versus ureteroscopy for ureteral stones, as well as a presentation by Dr. Dahl on our kidney stone study.
Hi, everybody. For those who don't know me, I'm Justin Nguyen, one of the PGY2 residents here. Looks like we have an exciting day of stones ahead of us. So I'm going to be talking about medical expulsive therapy. I chose this topic because as a PGY2, we often send patients home with Flomax medical expulsive therapy, but the data out there is actually pretty controversial. A lot of contradicting studies have come out recently. So I have no financial disclosures. So what we're going to be talking about is what is medical expulsive therapy, does it work, and who does it work for? Starting off with just a quick case presentation. So 38-year-old female presents with right flank pain, past medical history, hypertension, hyperlipidemia, afebrile, stable, creatinines at baseline, white counts 11, UA is non-concerning for infection, and her pain is well controlled. You get a CT scan non-contrast. It shows a 6 millimeter proximal stone with moderate hydronephrosis. And so what do? Most of us would send her home with Flomax. So just briefly touching on ureteral stones, why is it important? It affects up to 10% of the population with 340 per 100,000 ER visits per year. The cost of kidney stones is about 3 to 5 billion per year in ED visits and up to 10 billion a year just total for management. And so the predictors of stone passage are size, with smaller stones being more likely to pass, and location, with distal stones being most likely to pass. And this is pretty intuitive. So medical expulsion therapy is the use of a pharmacologic agent to facilitate the passage of stones. There's many agents that have been proposed and used. They are all off-label. None of them are FDA approved for this. The most common are alpha receptor antagonists, such as Flomax, tamsulosin. They target alpha-1 receptors, which have a high concentration in the distal ureter, supposedly helping to relax the ureter, reduce spasms, and help pass stones, and maybe even improve pain. But there's also been calcium channel blockers, phosphodiesterase inhibitors, and steroids, which have pretty much fallen out of favor. The proposed benefits: they can decrease pain, they can decrease stone complications, and they can decrease the need for invasive interventions. So what does the AUA have to say about medical expulsive therapy? So they recommend for uncomplicated stones, less than 10 millimeters in size, that especially distal stones, that medical expulsive therapy should be offered, especially with alpha blockers. This is a strong recommendation. And it's important to note that they do not endorse any other pharmacologic agent. And if the stone is not passed within 4 to 6 weeks, then they recommend offering definite intervention. The EUA has very similar guidelines. For stones less than 6 millimeters in size, they also recommend offering medical expulsive therapy. They do also specifically recommend alpha blockers. And they believe there's good evidence that medical expulsion therapy can accelerate the spontaneous passage of stones, as well as limit pain. So most of these recommendations and data were based on large meta-analysis. One of the best examples is this Cochrane review from 2014, which basically demonstrated that medical expulsion therapy could improve stone clearance. It could decrease the time to stone expulsion, about an average of 3 days. It could decrease pain, decrease need for pain control, and result in less hospitalizations. It was also associated with an increase in adverse effects, although these side effects were few and rare. But it's important to note that this was considered low quality evidence. The largest studies were only included less than 200 patients. There were only 6 studies that were double blinded, only 6 studies that were placebo controlled. And so, you know, they went ahead and they actually looked at just the placebo controlled trials. And when they looked at only placebo controlled trials, the effect of medical expulsion therapy was actually non-significant, p-value of 0.06. And so there was basically a call for more large, robust, randomized controlled trials to provide better evidence if this really does work, and who does it work for. So what I'm going to be doing is I'm going to be talking about 5 randomized control trials that have come out since this time that provided differing information. So the first major trial was the Suspend trial. It was published in 2015 in Lancet. It was done in the UK. It involved over 1,000 patients. It was a multi-center, double-blinded, placebo-controlled trial looking at Flomax versus nifedipine versus placebo over a 28-day period. It's important to note that, so they looked at all patients with stones less than 10 millimeters in size. And it's important to note that their primary endpoint was not stone passage. Rather, it was the need for intervention. And so they didn't actually confirm stone passage with any imaging. So looking at their primary outcome, need for intervention, they found no significant difference in the rate of stone passage. They were able to assess this primary outcome in 97% of the patients. And so you can see here that 80% of patients in all 3 arms did not require any intervention. Looking specifically at tamsulosin, you can see that there's no difference in stone passage with their subgroup analysis based on sex, stone location, or stone size. But it is worth noting that for patients with larger stones and for stones in the lower pole, they did show that tamsulosin may increase stone passage just with non-significant values, although the p-values were the lowest there, 0.13, 0.16. Lower ureter, yeah, that's right, yes. Looking at calcium channel blockers, similar but a reduced effect. And then looking at their secondary outcomes, they found no difference in time to stone passage, no difference in pain scores, use of pain medications, number of days needed for pain medications. They did a mental component score and a physical component score of their patients at this time. No difference between those. And there were very few adverse effects, no serious adverse effects in the Flomax group. So essentially, this trial recommended against medical expulsion therapy. They felt that medical expulsion therapy did not provide a benefit, but there were many critiques of this study. One of the main critiques was their primary outcome being that they didn't actually confirm stone passage. They just looked to see if the patients needed intervention. In addition to this, there's a high rate of stone passage among patients per their measure. 80% of patients didn't require intervention. This is higher than what is quoted in many other studies. And part of the reason is probably because most of their patients had very small stones, less than 5 millimeters in size. And so these stones would just pass on their own anyways. They didn't monitor medication adherence. And for their secondary outcomes, there was a very low response rate to their questionnaires. Only 62% of patients responded at 4 weeks. So the next study, this came out at around the same time. This was published in European Urology 2015. This looked at silodosin. This is another alpha blocker. This targets alpha-1A receptors, the second most, the second highest concentration found at the distal ureter. And once again, a multi-center, double-blind, placebo-controlled RCT done at 27 US centers, a much smaller sample size, 232 patients, looking at silodosin versus the placebo for 28 days. And they looked at patients with stones between 4 and 10 millimeters in size, confirmed with imaging, and their primary outcome was looking at if the stones passed versus with patient reports versus with imaging. So once again, looking at their primary outcome, they didn't find a difference in stone passage overall. There's no significant difference. But when looking specifically at distal ureteral stones, they found that stones passed at a rate of 69% in the Flomax group versus 46% at the placebo group. And this was significant with a p-value of 0.01. So this study basically showed that potentially medical expulsion therapy can benefit patients with distal ureteral stones specifically. Looking at some of their secondary outcomes, they also found that average pain scores improved in patients with distal stones on silodosin versus the placebo. It was a 0.03 p-value, but they found no significant difference based on stone size, the use of analgesics, the need for ER revisits or hospitalizations, or the need for intervention. They had very similar side effects. Only 4 patients in the silodosin group withdrew due to dizziness and nausea. So while that study showed that distal ureteral stones could be benefited, This study looked more at, this study actually focused on distal ureteral stones and kind of looked at stone size. So this was done in Australia, published in the Annals of Emergency Medicine in 2016. Another multi-center double-blinded placebo-controlled trial done at 5 Australian centers, including 403 patients. That looked at the Flomax group versus the placebo group over a 28-day period, with the primary endpoint being stone expulsion confirmed with imaging. And they also looked at time to stone expulsion. And they interviewed their patients at varying intervals at 7, 14, 21, and 28 days. And so this looks at all patients with stones less than 10 millimeters in size within the distal ureter. So their overall stone passage rate was once again non-significant between the two groups. But when they broke it down based on size, they found that for stones larger than 5 millimeters, there was a 22.4 increased stone passage rate, a significant p-value of 0.03 with a number needed to treat of 4.5. While looking at small stones, there was no significant difference. It is important to note that they were only able to get CT follow-up imaging on 80% of their patients. So the remaining 20% relied on patient-reported stone passage. And then when they looked at actual time to stone passage, they found patients on Flomax passed stones on average in about a median time of 7 days versus the placebo group taking about 11, p-value of 0.01. So this was non-significant. Looking at their secondary outcomes, they found no difference in need for ED representation, hospital readmissions, use of pain medication, or they actually found no difference in complications or adverse effects. So while the last trial showed that potentially distal stones benefited, this trial showed that distal stones greater than 5 millimeters in size potentially benefited. Just kind of going in chronologic order, this next study was published in 2017 in European Urology. This is actually the largest randomized controlled trial ever done on medical expulsion therapy. It was done in China, 30 different centers, including over 3,000 patients. They looked at all patients between the age of 18 and 60 with a very strict inclusion criteria of a stone between 4 and 7 millimeters in size in the distal ureter, all confirmed with imaging. Something that was unique about this study is they had every patient follow up at weekly intervals with CT imaging to confirm stone passage. And so they looked at the Flomax group versus the placebo group over 28 days, with the primary endpoint being stone expulsion confirmed on CT. So looking at the primary outcomes, they found an overall benefit of medical expulsion therapy between the two groups, although when they actually did a sub-analysis based on stone size, you can see that they actually didn't find a difference for patients less than 5 millimeters, and they did for those greater than 5 millimeters in size with a odds ratio of 2.05 and a p-value less than 0.001. So it does seem that for distal stones greater than 5 millimeters in size, that medical expulsion therapy may benefit. Looking at some of their secondary outcomes, so they actually showed that there was also an improvement in time to stone passage. Overall, the patients in the Flomax group passed their stones in 6 days versus patients in the placebo group took about 10 days. They found an improvement in need for pain medication. When they broke it up based on stone size, you can see that even though smaller stones did not show an improvement in stone passage rate or time to stone passage, they did have an improvement in need for analgesics and renal and pain in general, while for the larger stones, there was improvement across the board. And they did not find a significant difference in adverse effects between the two groups. The final study that I wanted to discuss, this is the STONE trial. This is the most recent study published. It was published in JAMA in 2018. This is the largest RCT ever performed in the United States. They did this in 2 phases involving 6 US centers and 512 patients, comparing Flomax over placebo for a 28-day period. And they looked at all patients greater than 18 years old with stones less than 9 millimeters in size. Something that was interesting is in their first phase, it was just done at a single center and they did not use confirmatory imaging. Their primary endpoint was actually patient-reported stone passage at 28 days. And so looking over all of their results, they did not find a significant difference in either rate of stone passage or time of stone passage across the board. They also didn't find any differences in many of their secondary outcomes, including hospitalization or need for intervention. The patient's self-reported adherence was about 80% in the two groups, and they were able to contact 97% of patients in 28 days to see if their stone had passed. Looking at a subgroup analysis, looking at stone size and location, they did not find any significant differences between the two groups based on stone size or location. So just to kind of summarize these trials, that two of these large trials basically found no benefit, while three of the trials seemed to find benefit for stones that were distal and larger in size. I think the best way to summarize this is looking at a Cochrane review done in 2018. This is looking at all meta-analysis, all RTCs done since this time. It includes 67 studies, over 10,000 patients, primary outcomes being stone clearance and major adverse effects. And once again, when they looked at all the studies, similar to the last Cochrane review, they found an overall significant increase in stone clearance. They also found an a decreased time for stone clearance, decreased need for pain medications, and a decreased need for hospitalizations. But most of this evidence was considered low in quality, similar to the last Cochrane review. When they looked at subgroup analysis, looking at stone size, they once again found that stones larger in size had an improved stone rate of passage, and across the board, stones had improved time to passage on FlowMax. Once again, low to moderate quality evidence. And then, what they did is they did a subgroup analysis, just looking at time to expulsion in patients with distal stones, and the same sort of thing. Stones that were further down in the ureter had an increased rate of stone passage on FlowMax. Similar to the last one, they looked at just alpha blockers. They looked at trials that looked at alpha blockers that actually had a placebo, and they once again found that stones had an increased rate of stone clearance overall, a decreased rate to stone expulsion, an increase in adverse effects, but no difference in need for pain medications or hospitalizations. And finally, something that they did different is they actually looked at high quality studies. And so they only included 5 studies in this analysis. And they actually found a significant improvement in stone clearance with a effect size of 1.09 across the board for rate of stone passage, with no difference in time to stone passage, need for pain medications, hospitalizations, or surgical intervention. Something that's kind of important to note and interesting here is they did not include the suspend or the stone trial in this high quality analysis. Those were the 2 studies that had overall negative results that we discussed earlier. And their reasons were basically because of the critiques that we discussed earlier, being that they didn't confirm stone passage with imaging, that they included large amounts of patients with small stones. Sure.
Based on this data,
Yeah.
what wording would you use to describe the anticipated effect? Would you say that over some period of time you have a 9% chance of passing your stone faster than an individual not on an alpha blocker? Or so how do you word risk ratio into an outcome?
Right. Yeah, I think you could probably say something along those lines. That it's.
I'm not asking you to speculate. Like, just what is the? How do you translate risk ratio into a sentence?
Right. Yeah, I guess. What are some conclusions that we can draw from all this data? So medical expulsion therapy likely seems to benefit stone clearance for stones, specifically in the distal ureter, 5 to 10 millimeters in size. What does medical expulsion therapy possibly benefit? It seems that it may benefit time to stone expulsion, especially for distal stones. It may benefit the need for pain and analgesic use. It may reduce the number of hospitalizations needed. It's always important to talk about the adverse effects, although most of the studies found that in general, it had a pretty low risk profile with very few major adverse effects. And I just wanted to mention some other possible uses for medical expulsion therapy that I didn't have time to discuss today, including use of medical expulsion therapy in the pediatric population, use after ESWAL, use before ureteroscopy, and possibly for polyp. Here are my references. Any questions?
Where they are in the ureter and what would you expect? Because I think there's confusion. I think if you look at all these studies, based on what I understand on the pathophysiology, and even in the JAMA medicine, they only divided it into upper and lower. And I would argue that that lower, there's a smaller percentage of distal. So it seems like the confusion comes from encompassing, bringing in all patients with ureteral stones, when in fact the efficacy and the pathophysiology would only point you to a benefit for the distal ureter.
Right, right. Yep. So essentially, the distal ureter has the highest number of alpha receptors. The highest concentration is alpha D receptors. That's what Flomax targets. Then alpha A, that's what philodocin targets. Most of these studies they used a cutoff of the sacroiliac joint as the cutoff for where a distal stone was actually located. And like you were saying, Dr. Shulam, it seems that they mostly just benefit distal stones. That stones in the proximal ureter, stones that were in the mid ureter, were not benefited by the use of alpha blockers.
But what I'm saying is that you found the study by doing stones outside the site of where
Exactly. Exactly. Yes, yes. And that was a big issue with both the Stone trial and the Suspend trial. They included a lot of patients, a lot of them that had stones that were outside. And so looking at the trial that just looked at the distal ureter, they found an effect. So Flomax is a cheap medication. It's a medication with very few side effects. It's very easy to take and give and use. And it seems to potentially have benefit and need for pain control, maybe a need for hospitalizations. It seems to maybe improve ureteroscopy. And so I think it's worth still giving. So I disagree with both the Stone and the Suspend trial, which recommended against giving any medical expulsion therapy in any scenario.
I want to kind of comment on what Dr. Shalom was saying. I think it's interesting that everyone's so focused on Flomax. They did some other studies, and obviously the side effects, you don't have to ramp up. But I can tell you, at least in the pediatric world, and I don't know if Angie or Dr. Weiss would say differently, we actually use terazocin because it's a little more generic. For things like stent discomfort, I don't use ditropan anymore. I usually use alpha blockers, as the residents know, for that kind of colic and stent discomfort because it's a little more generalized. Now, granted, you have to ramp up, so maybe the time to passage may be affected. But one could argue maybe you need something more general than specific, and they're just looking at the wrong thing.
Yeah, I think there were a lot of studies that looked. There were some studies that looked at other alpha blockers. It seems like across the board, except for I think alphazocin, they all seem to show some sort of benefit. So it doesn't really matter what alpha blocker you're using. I think most people just kind of default to Flomax because it's the most common we use and it supposedly targets the highest quantity of receptors in the distal ureter for the D receptors.
The problem is that it's hard to understand because we talk in Journal Club about how you randomize, and when you randomize, you take into account all the other factors that you're not measuring, right? What patients eat, what their habits are, and the bazillion other factors, if they should be equivalent in both groups. Yet despite these randomized studies, there are these differences that are found in these studies, and it's hard to understand why that is. The unfortunate thing is a lot of these studies were done early on when it was still being made by Boehringer Ingelheim, and now with a generic drug, I think less and less of these studies are being done. So I don't know if this answer will be determined. The funding for these studies will be compromised.
Someone presented with giving like a synopsis talk at one of the AUAs about this, and they did a subset, it was just a slide about what the chances of you passing a stone based on what country studies, and it was like if you're trying to pass a stone in the UK, you're not going to pass it. That was the initial study that showed. And if you're in Australia or China, it's something about the Chinese and Australians. And to speak truthfully, it may be their genetic predisposition for certain types of stones or their diet. So a calcium phosphate stone that's going to be, looks like rock candy is going to be less likely to, it's more jagged than, let's say, a monohydrate stone that's like a smooth pebble. So maybe that's the factor that they're not measuring, or what the stone composition is. Who knows? They're more resilient and willing to tough it out. What's the time frame that they were working with? Did they give them 2 weeks to pass the stone, or 2 months? So I think those are all factors that may be different in practice. Kind of similar to like the prostate cancer screening guidelines is like, where was your threshold? What was the cutoffs? When did you do a biopsy? How often did you screen? And so I think the Chinese studies are, you're not going to be able to replicate that in the States with getting weekly exams and an ultimate CT scan. But again, what genetic makeup are we not screening?
And another big difference between, for example, the UK study and the Chinese study is the UK study included all patients less than 10 millimeters in size, with 75% of those patients having stones less than 5 millimeters in size. A lot of those were just going to pass. Well, in the Chinese study, they only looked at patients with 4 to 7 millimeters in size. The average stone size was greater than 5 millimeters. And so, that probably played an effect.
Well, I always say, in the absence of data, or in the absence of good data, you have to make a decision of what sounds logical, and a decision of what you would do yourself or what you would want your family to do. And I think there's such a low side effect profile from it. And if it increases your chance even slightly to avoid an operation and avoid surgery, or to have 1, 2, 3 days of less pain, it's reasonable to try it. That's my philosophy on it.
I echo that sentiment. It's a low-risk drug. It's cheap. It's a little frustrating that the ER only sends the patients home with 7 days worth. It's like to pay another copay. So why not? I think we mentioned this in Journal Club about the cost of radical cystectomy doing robotic, and this is one of those things where if there is a questionable effect, you may not want to make a guideline statement about it and mandate it like that. But on an individual patient, when I'm seeing that patient in the clinic or in the ER, I'm going to do whatever I can to help give that guy, any chance of benefit with minimizing harm. So I don't think there's enough robust, maybe not enough to make a level 1 grade A guideline statement about it, but in practice, yes.
We use theophylline, which is a PDE inhibitor, and put it in the ureter after, let's say, pyeloplasties, when it didn't open up after you've removed your stent, and they had a nephrostomy tube or a pyelostomy tube. And people are going back to it, and I've heard they're using ROCK inhibitors and calcium channel blockers, which they're putting in the ureter and getting a local effect. And those will work, because if you take an isolated segment and you place one of those agents, they will dilate up the ureter. Now, the basic thing is whether to use it for stone depends on what the side effect profile. In fact, the reason why the alpha blockers are probably better than the PDE inhibitors, because the PDE inhibitors have other side effects systemically. And we used it in kids, which was very good, because in kids, their cardiovascular system is fine. We didn't see any side effects. But people are doing that again, and I think you'll see more of it.
Yeah. Yeah, there have been like a lot of studies on these different agents, and yeah, they don't really use that, and they don't really use steroids anymore just because of the side effect profile. And then calcium channel blockers, when they compare them head to head, it seemed like in most of the studies, alpha blockers worked better. So.
A little bit. It's a good intro by Justin, medical expulsive therapy. So I guess my talk will focus on what happens when that doesn't work or observation fails. Mainly going to be focusing on shockwave lithotripsy and ureteroscopy, and specifically in the management of ureteral stones. We'll start with a brief index patient, go on to talk about stone treatment modalities, mainly the ureteroscopy and shockwave, and get into our lit review and our conclusions. So to start with our case presentation, you'll have a 7-year-old gentleman who presents to your office, no prior history of stones. He was referred to you after having a 7-millimeter distal ureteral stone that they found in the emergency department 3 weeks earlier. He presented with right-sided flank pain. His vitals were normal in the ED. His UA was not infected. His creatinine was around his baseline, no white count. In your office, he has some mild persistent pain. It's been 3 weeks. It's probably about the time you'd start considering booking the patient or talking to the patient about things that would, how to treat this, and have a discussion if he wants to have it treated. As Justin told us eloquently earlier, one of our guidelines actually says if medical expulsive therapy or observation are not successful after 4 to 6 weeks, then you can offer them definitive stone treatment. So to very briefly go over our stone treatment modalities, we all know ureteroscopy with laser lithotripsy. They have long and short semi-rigid scopes and flexible ureteroscopes that we're all quite familiar with. You can use our lasers. I think this is what a lot of the other services in the hospital think we do when we talk about laser therapy, but we all know it's a little bit more refined. We use our holmium lasers. We can dust, fragment, and basket the stones out however we please. But what we're going to be focusing on a lot today is shockwave lithotripsy. This is actually an old picture, not to surprise some of you, but I think I've actually had patients when they come in are telling me like, oh, they're surprised that they're not getting into a bathtub for the procedure. Realistically, what we do looks something more like this. And in paging and surveying a lot of our residents, I was actually surprised to find that a lot of our residents aren't aware that shockwave lithotripsy can be used for treatment of ureteral stones. There is definitely data supporting it, and we'll get into that data. But for those of us that are a little bit less familiar with shockwave lithotripsy, I'll just very briefly review it. So the basic mechanism of action, very simplified because there's a lot of physics that go into it, is you have a machine, a lithotripsy, that through some mechanism generates a shockwave. That shockwave then gets directed and focused into the body, and then that can fragment the stone. The way that machine works is where there's differing technologies. The original was electrohydraulic. Then they create electromagnetic. We use piezoelectric, where we put electricity across these hundreds of little crystals that then vibrate and generate a shockwave. Briefly, to go over some of the uses and contraindications. A lot of these were formed around the use of shockwave lithotripsy, specifically in the kidney, but I think it applies. You would not want to use it if you have an active urinary tract infection, if the patient has any uncorrected coagulopathy or bleeding disorders, if there's a pregnant patient, or if there's an uncorrected obstruction distal to the stone. If you think you're going to fragment the stone and there's a stricture distal, might not be the best option. Then some things that you just want to really consider in counseling patients on shockwave lithotripsy is their body habitus. You want to consider the skin to stone distance, stone size, any renal malformations like horseshoe kidney, complex renal collecting systems, hypertension and renal insufficiency were shown to be correlated with poor outcomes with shockwave lithotripsy. And lastly, something to keep in mind is that there's no real documented treatment protocol. There's lots of variations that providers can use when they choose to do shockwave lithotripsy, which is important for a lot of the studies that we talk about. You can use a different amount of frequency, how many shocks you deliver per minute, how strong those shocks are, how quickly you get to maximum strength, the number of total shocks that you deliver, and how you position the patient. These are all up to the provider. Let's get into the meat of the talk. We'll get into our literature review. Not as much recent data, but we'll start back where I think it's relevant. Back in 2007, the EAU and the AUA conducted a nephrolithiasis guideline panel. They did a systematic review of all studies that they could find since 1997 that had to do with shockwave lithotripsy or ureteroscopy, whether it was comparing the two or whether it was single cohorts looking at the results of one study alone. They synthesized the data. They further broke the data down into subgroups relating to stone size and location. And one thing, the primary outcome that they looked at was stone-free rate. One of the primary outcomes was stone-free rate. And one thing I'll talk about a lot throughout this talk is stone-free rate is a variable definition. Every study that is conducted with shockwave lithotripsy or ureteroscopy has a different definition of stone-free rate. It can be stone-free weeks after the procedure or up to 3 months after the procedure. And a lot of the studies that it can include retreatments with the same procedure, and you can still be considered stone-free. So what did they find in 2007? They found that ureteroscopy, as you can see by the top box over here, was better than shockwave lithotripsy across the board in all locations for stone-free rate in the distal ureter. And then in the proximal ureter, ureteroscopy was only better than shockwave lithotripsy for stones that were greater than 1 centimeter. As far as complications, they looked at things like sepsis, Steinstrasse, stricture rates, ureteral injuries, UTIs, and the complication rates were higher for ureteroscopy across the board as compared to shockwave lithotripsy. As you would expect, shockwave lithotripsy less invasive. So at the end of this analysis and systematic review in 2007, they made a joint statement making a recommendation that for patients requiring stone removal, both shockwave lithotripsy and ureteroscopy are acceptable first-line treatments for ureteral stones. However, you have to counsel patients that there's a higher stone-free rate with ureteroscopy, but more complications. Then in 2010, there was a pretty good prospective randomized controlled trial done by a group in Italy that's often cited in all these more recent papers. They did a prospective controlled trial with 273 patients that were included. The inclusion criteria were patients with solitary, unilateral, radio-opaque stones in the distal ureter between 5 and 15 millimeters, requiring active intervention. They excluded all patients that I mentioned previously would be excluded from shockwave lithotripsy. And they further broke the study down into by stone size less than or greater than 1 centimeter. They got weekly KUBs and ultrasounds to assess stone-free status, and it was defined as absence on imaging at any time within 3 months. But stone-free rate in this study also included retreatment, so you could have been retreated and be considered stone-free. So their publication ended up saying that stone-free rates are equal, 93% in shockwave and 95% in ureteroscopy. However, in looking at the data further, what I highlighted here is that 45% of the patients that were stone-free in shockwave lithotripsy required a retreatment, another shockwave treatment, compared to 8% of the patients with ureteroscopy. When they broke down the data further to look at subgroups, based on stone size less than or greater than 1 centimeter, within shockwave lithotripsy, if it was greater than 1 centimeter, they were found to have higher retreatment rates. This is actually important for the recommendations that they make, because if you look for shockwave lithotripsy less than 1 centimeter in this study, they found that the stone-free requiring retreatments was only 12%, whereas greater than 1 centimeter was 80%. There's higher need for auxiliary procedures, and that's defined as any unplanned intervention or additional procedure along with shockwave or along with ureteroscopy that includes placement of stents. Then, higher complication rate overall with greater stones. So their conclusions were a little bit different and go a little bit counter to what I think a lot of us think today. They said in 2010 that SWEL should actually be the first-line recommendation for distal stones less than 1 centimeter. However, they acknowledge higher retreatment rates, especially in those with stones greater than 1 centimeter, and lower rates of things such as stents. For ureteroscopy, they said that should be used for distal stones greater than 1 centimeter as a first-line treatment. Then in 2012, the Cochrane database looked at this as well. They looked at all ureteral stones, compared shockwave lithotripsy versus ureteroscopy. They did an extensive search for any randomized controlled trials, and they found only seven in 2012 that were included, a total of 1,205 patients. And again, they looked at stone-free rate, retreatment rates, the need for auxiliary or unplanned procedures, hospital stay, and complications. For stone-free rate, it favored ureteroscopy. You're 16% less likely to need a retreatment with ureteroscopy than with shockwave lithotripsy. For retreatment, you're about I think I may have misspoke. 16% more likely to pass a stone with ureteroscopy than shockwave lithotripsy. For retreatment, you're about 6 times more likely to need retreatment with shockwave lithotripsy than with ureteroscopy. For auxiliary procedures, including things like stents, you're about 50% less likely to need one of those procedures with shockwave. And this is something that I want to stop on for a second, because this is pretty important, especially when we talk about stenting, which is done almost universally with ureteroscopy. Starting to take call this year, I can tell you most certainly stenting is not benign. Being woken up in the middle of the night to see patients in the emergency room with stent colic, I'm sure higher rates of analgesia use with patients with stents, general patient discomfort. I think this is something that definitely patients need to be counseled on at all times when they have a ureteroscopy, because we almost always leave a stent in place. Complications, they found that they were about 50% more likely to have complications, mainly including ureteral injury, strictures, hematuria, hematomas, and UTIs with ureteroscopy as compared to shockwave lithotripsy. You're going to have a shorter hospital stay with shockwave lithotripsy than ureteroscopy, as you'd expect. And so at the end of the review, they made their statement on implications for practice. And basically, they said that based on the heterogeneity of evidence, that they could not recommend a change in practice. This heterogeneity includes the difference in stone-free rates, the difference in technologies. A lot of the studies that were used are from different times, different shockwave protocols, different shockwave technologies that were used. So they couldn't make any implications. That was 2012. That brings us to the more recent systemic reviews and what our current guidelines are based off of. Our current AUA guidelines are regarding ureteral stones are based off of a systematic review of all literature pertaining to observational studies, included single cohort studies, so that they could collate the data and make recommendations. I don't expect you to read this at all. I just want to show you that these are the 55 studies that our current guidelines are based on pertaining to ureteroscopy and SWEL when they make recommendations for whether you should use. And I want to point out that some of the studies, the oldest study is from 1966. So our current guidelines are based and include studies that go back to 1966. They found in this review a superior stone-free rate for ureteroscopy over shockwave lithotripsy, 90% with ureteroscopy versus 72% with shockwave lithotripsy. For stones less than 1 centimeter stratified by location, ureteroscopy was superior for stone-free rates at all locations than shockwave lithotripsy. For stones greater than 1 centimeter, the rates were comparable in the proximal ureter, but ureteroscopy was greater in the mid and distal ureter. This actually goes opposed to what that first prospective study I talked about showed. They also went on to say that ureteroscopy is more likely than SWEL to successfully treat a patient with a less than 1 centimeter ureteral stone in a single procedure. These show you the mean number of primary procedures needed to become stone-free. And again, that definition of stone-free that they looked at varied amongst all studies. So our current recommendations are as follows. We say that shockwave lithotripsy, you should inform your patients that shockwave lithotripsy is the least morbid, lowest complication rate, but the ureteroscopy has a greater stone-free rate in a single procedure. And in regards specifically to mid or distal ureteral stones, they recommend ureteroscopy as first-line therapy. And then for patients who decline ureteroscopy, you can offer shockwave lithotripsy. They go on to explain that this needs to be a nuanced, patient-centered discussion, and that you need to include things like the likely need for stents with ureteroscopy and whether patients are okay with that, and that should guide the discussion. I was just interested and curious to see how the EAU compared with their current guidelines. They have more recent guidelines that were updated this year. And their 3 statements on this kind of say that stone-free rates are better at 4 weeks for ureteroscopy, but at 3 months are actually equal. They say that shockwave lithotripsy requires more treatments, but ureteroscopy has higher adjunctive procedure rates, such as stenting, and higher complication rates. And that ureteroscopy is better for those that are obese and severely obese. So they make recommendations stating that you should inform patients that if they want a single procedure, ureteroscopy is the way to go. You have higher complications with ureteroscopy, and those that are severely obese should be counseled that ureteroscopy is a better option for them than shockwave lithotripsy. So they have a little treatment algorithm that they published also, which basically says that for any stone greater than 1 centimeter, ureteroscopy should be first-line treatment. But how they differ from us is that for stones less than 1 centimeter in the distal ureter, they say that there is no difference, and you can offer both shockwave or ureteroscopy as first-line treatment. So to get to our conclusions, I think ultimately, when you're in your office talking to patients about how to treat their ureteral stones that have persisted or not passed, or for whatever reason you're deciding to intervene on, you need to have a frank discussion with them. Tell them that SWEL is less invasive, less morbid, has a higher retreatment rate. If you decide that, and if you elicit that from the patient, their biggest factor is that they want this done in one procedure, then ureteroscopy is the way to go. But they need to understand the risks of complications and secondary procedures such as stent placement and associated complications with that. And then you must take into account comorbidities of patients and the accessibility of treatment options. I think it's a lot easier for us to book a ureteroscopy than I think for a lot of us it is to book a shockwave lithotripsy. And then some other conclusions. Obviously, better studies are needed. An important thing that I noted here is that we need a better standardization of our primary outcomes when we're comparing these things. Stone-free rate should be defined as one thing across studies. Have a common endpoint, whether that's 1 month, 3 months. and whether that includes retreatments or not should always be noted. And it would be interesting to have a cost-effect analyses. There are some out there. I couldn't find some good ones to include, and I don't think there was enough time to talk about it. But going into which treatment, in one study, in one treatment is more cost-effective is one thing. When talking about retreatments and complication rates and visits to the ER for stent colic, these kind of add a lot of factors as to what might be cost-effective for our system. So I'll bring you back to our index patient who sees you after 3 weeks with a 7-millimeter right distal ureteral stone. He's got some significant medical history. He's got heart failure, diabetes, hypertension. Hopefully you would counsel this patient, based on their needs and what they most desire. Any questions? Thanks.
There was a time when we utilize stone density measurement by Hounsfield units to decide how we approach, particularly stones in the proximal ureter. You didn't comment on that. Is that still a valid parameter in addition to stone to skin distance?
Yeah, I think using Hounsfield units, the harder the stone based on CT, if you have that evidence, it's been shown to be associated with less likely of passage and less likelihood of success with Shockwave.
And that was also, and I'd ask Bruce to comment on this, sometimes if there was a 1 centimeter stone in the renal pelvis that you would normally attack with Shockwave lithotripsy, if it was a terribly dense stone, somebody that's obese, you'd probably offer that patient ureteroscopy as well. Is that correct?
Yeah.
I just want to make one last comment. I understand some of these things are outside the scope of the talk, pediatrics being one of them, but you're making the assumption that we're always comparing ureteroscopy with stent versus no stent for Shockwave, but for larger stones in some populations, you would utilize a stent for some recommendations. Pediatrics.
Pediatrics. Yeah, in the adult population.
Focused on here. I agree. I said pediatrics may be outside the scope of what we're interested in, but for some of us in the back of the room with this. So raise that. The future.
And just to add a number to that, it's about 1,000 Hounsfield units that is considered hard and likely not to respond to Shockwave lithotripsy. Stephen Dretler did that work and coined the term durility, the durility of a stone. And yes, that has an impact because of the energy that will reach the stone. The other thing I would add to your talk too, and we've had this discussion at M&Ms in this room often about anticoagulation. Should you stop it? Should you do an operation on it? That's come up multiple times, and it's more and more relevant as more and more patients are on anticoagulation, have heart disease, have drug-eluting stents or strokes, is that with Shockwave, they cannot be on an anticoagulation. And with ureteroscopy, I never stop anything. They could be on Plavix and aspirin, and it doesn't matter. I never stop it. So.
Lower pole of the kidney, but if you're particularly the distal ureter, which I don't do too many, but if you're in the mid to distal, you're not going through, your shock is not going through the kidney, you could pretty safely use at least aspirin. I mean, the other issue is just you alluded to is the practicality of it. Mm-hmm. You admit a patient with an 8-millimeter proximal ureteral stone, you have ureteroscopy 24 hours a day, days a week. You have Shockwave 1 day a week. You're not going to have a patient wait 6 days to get a treatment. If it were available every day, we'd probably do more of them approximately.
Thanks.